Hello viewers, welcome to this episode of Healthy India. As you're all aware, there has been a considerable increase in the number of COVID-19 cases diagnosed across the country in the last few weeks. In particular, this increase has been seen in the metros, especially Delhi, for example. We also know that we had the last surge of cases in January and February when Omicron hit us, and we realized at that time that the disease is little different from the earlier two waves that we saw in 2020 and 2021. After that, we went into a lull and the number of cases dropped sharply. But now, in the last few weeks, there again has been an increase in cases. This has fueled a lot of anxiety, a lot of concern. Are we heading into a devastating fourth wave of COVID-19? However, we have realized that there is not a major wave in the offing. It's not overwhelming our health services. The number of sick patients requiring hospitalization, oxygen, and succumbing to the disease itself is very, very low. When COVID-19 started in 2020, it was a new disease for everybody. And doctors were learning on the job. The treatments were just being developed. Clinical trials were not there. And therefore, we were all sort of going by logic and past experience. In the second wave, that is the devastating Delta wave, we had learned much more about the disease. And therefore, treatments were more directed and focused. It's a different fact that the virus was in a very bad form, so to speak, at that time, and we witnessed a pretty bad phase exactly a year ago. When Omicron came in January, there were concerns, but data from South Africa and subsequently our own experience showed that it's pretty mild. And therefore, the treatments for this disease have also evolved accordingly. It's not the same way that we were treating the first wave, patients in the first wave. That's not the way we treat patients of COVID-19 now, but we need to know from our frontline experts. And today we have with us in the studio Professor G.C. Khilnani, who is the Chief of Pulmonary Medicine, Sleep and Critical Care at the PSRI, formerly Professor of Pulmonary Medicine at the All India Institute of Medical Sciences. And we have Dr.Sushila Kataria, who's Head of Internal Medicine at the Medanta, the Medicity, and has considerable experience in treating these patients right from the time COVID-19 started in India. One of the first to actually have hands-on experience with that. So thank you for being with us. I'll start with you, Dr. Khilnani. I mentioned briefly, what is the difference in clinical presentation now versus, say, January, February? Is there any difference or is it about the same?
So thank you, Dr. Ambrish, for having me here. So answering your question, the initial presentation of whether it was first wave, second wave or third wave or the currently outbreak that we are seeing is the same. And that is a mild fever, body ache, running nose, scratchy throat, little bit of cough, backache, little bit of joint pain sometimes. Some people have gastrointestinal, meaning by indigestion or loose motion. All those are not different. What is important is how it progresses. As we all know, during the first and second wave, starting from 4th to 5th day, person starts getting breathless, his oxygen goes down, what we typically called as happy hypoxia, meaning thereby that people had pneumonia. And sometimes they required intensive care, sometimes they were on ventilators, sometimes patients could not be saved. Fortunately, that is not happening this time. Currently, the cases that we have reported in Delhi, something like 1,500, and my thinking is that cases are more than thousands because not everybody is being tested. Asymptomatic cases are too many, the scare is not there. The number tested are also very few. But this time, we have admitted patients not because of COVID, but with COVID. What I want to say is that Patients have severe disease, they are 80 years old, they have heart disease, diabetes, or they are post-cancerous, or they are on chemotherapy, and since they are COVID positive, as a matter of caution, we have admitted them. But we haven't seen pneumonia that we saw, we haven't seen reduction in oxygen, and we haven't seen any mortality.
So it's following the same lines as the Omicron wave that we saw in January, February, somewhat. Somewhat similar lines.
Exactly
right?
so. Exactly so. But I would say that as far as the severity of illness is concerned, it is lesser than Omicron. That's my personal experience, not quoting any data. And I have a reason for that, because currently, if we talk about India, almost more than 90% of people have already got infection. That's what clinicians believe. And more than 70% are completely vaccinated. And this makes a person a robust immune person. And that leads to mitigation of the severity.
So that's good news. And as we all are aware again, that cases are increasing rapidly, but it's not coming like a surge. And certainly it's not overwhelming our healthcare system at the moment. And it seems like this is an Omicron variant. Whatever genomic data is now appearing suggests that this is an Omicron or Omicron variant, of which is a coronavirus variant. So what is important to understand is that what the fundamental difference is that COVID-19 in the first and second waves was affecting the lungs. And you were getting hypoxia, as Dr. Khilnani mentioned, drop in oxygen. Remember the craze about oxygen and the worry about oxygen, rightfully so. This time it's more and more localized to the upper respiratory tract. So I think that's the main difference, and encouraging to know that we are not getting overwhelmed or not getting, crushed as we did in the second, the Delta wave. Dr. Kataria, we all realize that COVID-19 is a viral infection. So our viewers are always concerned, treatment क्या है? Treatment तो बताइए, आपने दवाई क्या दी उसके इलाज के लिए? तो वायरल इन्फेक्शन का ट्रीटमेंट तो एंटीवायरल ड्रग्स ही होगा. एंटीवायरल ड्रग्स का लिमिटेड रेपर्टोयर है. Antiviral drugs are not like antibiotics where you have a whole array to choose from. So when we talk of viral infections, we talk of antiviral drugs. Now, just to put it in perspective, common cold is also a viral infection. Now, but we don't use any antiviral drug for that. So antiviral drugs are not that clean. So with the advent of COVID-19 and numerous waves, there has been resurgence of interest in antiviral drugs. So very quickly, I'll ask you about the first antiviral drug that was used in this, especially in the first wave and the second wave, remdesivir. So where are we now with remdesivir?
So remdesivir, yes, it was considered as panacea at one time. But with the course of time, we realized that it is beneficial. It may not be the all cure, but it does help in a given situation. So antiviral, the viral replication is very much in the early stage of the disease. Right now, also the recommendations, people who are likely to deteriorate because of our understanding of the disease, people who are very extremes of age, malignancy patients, immune compromised, patients on heavy immune suppressant medication, diabetics uncontrolled, so and elderly age group. These patients, if they are administered remdesivir early in the disease, OPD treatment totally, 3 days, 3 doses is to be given, that helps in reducing the disease severity. And this holds good in Omicron, Delta and all variants, even in B2 variants. So this is one which hasn't changed much. Its timing has changed, its duration has changed, which was 5 days.
So the timing is very important, Dr. Kataria. What was initially recommended for remdesivir was to use it much later in the course in hospitalized patients. But the understanding is that the viral replication happens in the earlier part.
Very true.
And so it stands to logic that the drug will work better in the earlier part, which is what we are finding now.
Absolutely. So during the course of our research and trials, we found that it is the earlier phase, earlier you give. How soon you give, if you give it on day 1, day 2, even better. But giving it in the first 1 week is very, very important. And it can be administered on an OPD basis. We know that its safety is good. Even in patients with renal compromise, it can be given with total monitoring. So there are not many contraindications to it, but people have to, with the kidney disease, liver disease, has to be careful, but this has, done good work.
So, but it has to be given in hospital, right? It's not easy to administer at home. People may come for daycare and go back if required, right? Okay. Dr. Khilnani, about a drug that was much talked about in January and February, molnupiravir. Where do we place? I'm talking of antiviral drugs. For our viewers, we are discussing antiviral drugs. Molnupiravir.
So, there has been the focus of management of COVID has been from treating a severe cases to giving treatment early so that people do not reach the severe stage.
Absolutely.
And with that in mind, antiviral drugs were tried. As remdesivir, as Dr. Kataria mentioned, it reduces the severity by 85%. But there is a difference of opinion that if the patient travels to the hospital, COVID patient, for remdesivir, he is liable to communicate at so many stages. So everybody does not agree that it should be given on the OPD basis. Personally, I would admit that patient. But there are two drugs which were tried. Prior to that, the hydroxychloroquine, favipiravir, all drugs failed, and also ivermectin failed in randomized trials. So they were given up. So two antiviral drugs, molnupiravir and Paxlovid, were tried in the randomized way. When they were given, first I'll talk about molnupiravir because that is available in India. It is an oral drug. When given in first 5 to 7 days, it reduces the severity to the tune of 30%. Now, this cannot be given to the patients who are less than 18 years of age, those who are pregnant or even wanting to become pregnant, or even the male people if they are indulging into upcoming family. It should not, because it affects cartilages. It has some GI side effects, but it is remarkably safe drug and we have used it all. It has to be given for a period of 5 days in the dose of 4 capsules twice a day. And there is one randomized study which has shown that it reduces the severity. The other drug that is a combination of two drugs is Paxlovid, which is available in the Western country and unfortunately hasn't come to India. It is more efficient in reducing the severity to the tune of 85% as shown in the, but currently it is not available, so let's not discuss that. So one should not think that these drugs have to be given in every COVID positive patient. There are defined indications, as Dr. Kataria mentioned, that people who are elderly, diabetic, or on chemotherapy, or coronary heart disease, meaning thereby those who are at high risk of severe disease and death. These are the people when they are found COVID positive, if we give these oral drugs, they reduce the severity and there is a robust scientific evidence for that. And as Dr. Kataria mentioned, it is effective for Delta as well as Omicron virus both.
So thank you, sir. With this, we'll take a short break and we'll be back with you with more information about treating COVID-19 in 2022. Welcome back after the break. And as Dr. Khilnani explained, that there are numerous antivirals, at least 3, that have been sort of successfully used in COVID-19. However, it does seem that most of our patients in this surge and the previous wave don't really require this medication. So it's important not to fret over lack of availability of this or that. By and large, the patients can be managed without these medications, but there are specific instances where they should be used and are being used. I'll come to a second group, Dr. Kataria. The other group that has gained a lot of traction in the media, a lot of discussion, is the concept of monoclonal antibodies and how they work in COVID-19. And of course, there was this thing that they work and then they don't work for this one and they don't work for Omicron and new ones work. Where are we with monoclonal antibodies?
So monoclonal antibodies are also very interesting concept, not only in COVID-19, it's been used in cancer, it's been used in a lot of autoimmune problems, but we know more due to COVID. So monoclonal antibodies also, they neutralize either the binding of the virus or it is the effect of the virus, or somehow they make the virus useless. So monoclonal antibodies came with a lot of hope. Like we found a good treatment with the remdesivir, with the monoclonal antibodies of Regeneron and all these antibiotics, the casirivimab, amdevivimab, which was very, very effective for Delta, and it reduced mortality by 70%. So something which was after steroid, which was reducing mortality, was monoclonal antibodies. But then came Omicron and we realized that in the laboratory, it was not neutralizing. So then came sotrovimab. Now, sotrovimab is effective in Omicron B1 variant, but it is not effective in B2 variant.
Yes.
So then we have bebtelovir. So a lot of monoclonal antibodies are coming. It's like, you have a dye and you make copies of it. So that's how the monoclonal antibodies work. The speed with which monoclonal antibodies are being made, I think it's a promise not only in COVID, in many other infectious disease, that we'll find quick results with less side effects and with more efficacy.
But at the moment, in the kind of patients we are seeing and the kind of monoclonal antibodies that are available here, there is very little role, right? There's
Absolutely. I mean, the casirivimab is not to be used after Delta. Now, sotrovimab is also, because the predominant variant is beta-2 variant now. Yes. And bebtelovir, we do not have it. So right now, there is
limited, very, very expensive therapy. और आपको जानना चाहिए कि मोनोक्लोनल एंटीबॉडीज बहुत अच्छा ट्रीटमेंट है, लेकिन इस समय जो वायरस सर्कुलेट कर रहा है इंडिया में, उसमें उसका बहुत ज़्यादा रोल नहीं है और एक्सपेंसिव ट्रीटमेंट है, बहुत सेलेक्टिवली यूज़ होना चाहिए, पर फिलहाल उसका इतना ज़्यादा रोल नहीं है. तो एंटीवायरल थेरेपीज़ का भी लिमिटेड रोल है और मोनोक्लोनल एंटीबॉडीज़ का इस समय हमारे देश में बहुत ज़्यादा रोल नहीं है कोविड-19 के ट्रीटमेंट में. डॉक्टर खिलनानी, हर चीज़ में लोग एंटीबायोटिक दे देते हैं. मेरी तो ज़िंदगी भर की लड़ाई रही है एंटीबायोटिक्स के खिलाफ, और मैंने पहले ही बायस्ड स्टेटमेंट दे दिया एज एन एंकर. बट आप बताइए, व्हाट डू यू थिंक अबाउट एंटीबायोटिक रोल इन
नहीं, देखिए ऐसा है कि जो हम स्पेनिश फ्लू की बात करें तो उसका एविडेंस ये है कि ज़्यादा लोग की डेथ हुई थी सेकेंडरी इन्फेक्शन से रादर देन बिकॉज ऑफ द फ्लू वायरस. अगर उसको हम एक्स्ट्रापोलेट करें, तब तो कोई एंटीबायोटिक अभी आई नहीं थी. 1940 में पेनिसिलिन आई थी. तो लेकिन ये है कि जितने भी लोग आईसीयू में होते हैं, वेंटिलेटर पे होते हैं, जिनको वायरल निमोनिया होता है, उसमें पोटेंशियल होता है व्हाट वी कॉल है सेकेंडरी इन्फेक्शन. तो सेकेंडरी इन्फेक्शन जब होता है तो एंटीबायोटिक देनी होती है. लेकिन सेकेंडरी इन्फेक्शन डायग्नोस कैसे करें, क्योंकि पहले ही निमोनिया है, एक्सरे सीटी करेंगे तो पता नहीं चलता कि ये निमोनिया बैक्टीरिया की वजह से है या वायरस की वजह से. लेकिन कुछ पैरामीटर्स होते हैं, जैसे ब्लड काउंट्स होते हैं, प्रोकैल्सिटोनिन है, इस तरह की कुछ पैरामीटर्स होते हैं जो, और फिर ब्लड कल्चर्स होते हैं और रेस्पिरेटरी सिक्रीशंस के कल्चर्स होते हैं. ये एक बहुत ज़्यादा क्लिनिकल वो है, इस पर ज़्यादा मैं नहीं जाना चाहूँगा. लेकिन ये कि अगर आपको एक हाई इंडेक्स ऑफ सस्पिशन रखना होता है कि इनको अगर बैक्टीरियल इन्फेक्शन है तो समय पे एंटीबायोटिक, जैसे आपने शुरू में कहा कि भाई बैक्टीरिया के लिए एंटीबायोटिक बहुत ज़रूरी होते हैं और इफ़ेक्टिव भी होते हैं, लेकिन उसका डायग्नोसिस बहुत ज़रूरी होता है. और वो डायग्नोस करने के लिए बहुत सारे टेस्ट होते हैं हमारे पास. अगर आप समय पे डायग्नोस करेंगे इन्फेक्शन का तो उसका इलाज होगा और उसका डेफिनेट यूज़ है. लेकिन ब्लैंकेट यूज़ ऑफ एंटीबायोटिक, कोविड डायग्नोज होते ही एजिथ्रोमाइसिन शुरू करना, उसका कोई रोल नहीं है. कोई जिसको पहले दिन कोविड पॉजिटिव आया और आपने 1 और 2 एंटीबायोटिक और स्टीरॉयड शुरू कर दिया, वो बिल्कुल गलत है. आप उसका पेशेंट का भी नुकसान कर रहे हो, उसके साइड इफ़ेक्ट होते हैं, उसके गैस्ट्राइटिस होती है. यू आर क्रिएटिंग ड्रग रेजिस्टेंस इन द कम्युनिटी. तो इसलिए ब्लैंकेट एंटीबायोटिक नो, जब आप सेकेंडरी इन्फेक्शन डायग्नोज करें तो एंटीबायोटिक का डेफिनेट रोल है।
I feel that azithromycin would have stopped working in Indians anyway now.
Absolutely.
I doubt it very much.
Absolutely.
Dr.
I totally
Kataria.
agree.
मैं भी और इसी बात को सेकंड करना चाहती हूँ कि मोस्टली लोग कहते हैं मुझे वायरल हो गया, मैंने एंटीबायोटिक खा लिया। ये अपने आप में एक पैराडॉक्सिकल स्टेटमेंट है। तो एंटीबायोटिक्स का कोई रोल नहीं है कोविड में until unless there is a secondary bacterial infection।
वो तो सीरियस पेशेंट्स
और वो बाद में होगा। तो
डॉक्टर डिसाइड करेगा सीरियस पेशेंट।
हर बुखार को, हर गले खराब को एंटीबायोटिक वैसे भी नहीं लेनी चाहिए।
इसी के साथ जुड़ा हुआ डॉक्टर खिलनानी, we are always concerned about steroids, and we've seen there was some misuse of steroids in the first and second waves, and whereas steroids are not antiviral agents, steroids are not monoclonal antibodies, steroids were used for a specific purpose of reducing the inflammatory response or suppressing that. So with this current wave, current surge, where do you put steroids?
तो हिस्ट्री की बात करें तो वायरल निमोनिया, स्पेशली जो H1N1 जो को आउटब्रेक आया था जिसमें डेथ्स भी हुई थी, उसमें स्टीरॉयड्स वर काउंटर प्रोडक्टिव। मतलब स्टीरॉयड दिए तो आउटकम ख़राब हो जाता था, उसके बहुत सारे साइड इफ़ेक्ट्स होते हैं। लेकिन कोविड में ये जाना गया कि कोविड भी वायरल निमोनिया है, तो उसमें जो रिकवरी ट्रायल हुई थी उसमें जब स्टीरॉयड दिए गए मॉडरेट डोजेजेस में तो मोर्टेलिटी बेनिफिट, मतलब कम डेथ्स हुई। लेकिन इसमें एक बात है कि अगर आप स्टीरॉयड हर पेशेंट को देंगे जिस समय वायरल रेप्लिकेशन होता है, उस समय आप स्टीरॉयड देंगे तो वायरल रेप्लिकेशन बढ़ता है, उससे एडवर्स आउटकम हो जाता है। तो स्टीरॉयड देने के डिफाइंड इंडिकेशंस होते हैं, डिफाइंड टाइम होता है। उसमें स्पेशली जो है जब ऑक्सीजन कम हो जाता है या फिर एक पैरामीटर होता है सी रिएक्टिव प्रोटीन, वो बहुत ज़्यादा होता है, वो एक इंडिकेशन होता है स्टीरॉयड देने का। और उसके डोजेजेस भी डिफाइंड हैं क्योंकि बहुत सारी ट्रायल हो चुकी हैं। लेकिन स्टीरॉयड के साइड इफ़ेक्ट्स तो बहुत सारे देखे, डायबिटीज़ क्या, और जो ब्लैक फंगस जो हुआ वो उसके आप खुद मास्टर हैं डायबिटीज़ के, तो बहुत सारे साइड इफ़ेक्ट हुए। और अगर मिसयूज़ की बात करें, एंटीबायोटिक के मिसयूज़ से नुकसान हुआ इतना हम उसको नाप नहीं सकते, लेकिन स्टीरॉयड से जो नुकसान हुआ है भारत में उसको तो हम नाप सकते हैं, बहुत ज़्यादा नुकसान हुआ। तो मैं आपके माध्यम से बताना चाहता हूँ कि स्टीरॉयड आर लाइफ सेवर्स फॉर कोविड, लेकिन उनको कब देना चाहिए वो सिर्फ डॉक्टर की सलाह से ही लेने चाहिए। ओवर द काउंटर और सुप्रा नॉर्मल डोजेजेस में 10-10 गुने ज़्यादा डोजेज दिए गए। किसी को तेज़ बुखार हुआ है, बहुत तेज़ 105 बुखार हो रहा है तो स्टीरॉयड देना ज़रूरी है, ये सब गलत है। और अब जो आपने प्रश्न पूछा, जो ये वेव है, जो वेव या जो भी मैं कहूँ आउटब्रेक है, जब केसेस हो रहे हैं, जो मेरा इसमें एक्सपीरियंस है कि ये बहुत माइल्ड डिजीज़ है। मैंने कोई केस ऐसे नहीं देखा जहाँ पर मुझे स्टीरॉयड यूज़ करना चाहिए, लेकिन आंखें खुली रखनी चाहिए।
हाँ बिल्कुल।
किसी के चेहरे पे लिखा नहीं होता कि ये ओमिक्रॉन या B1 है या B2 है या डेल्टा बिल्कुल ख़त्म हो गया, इसका हमारे पास कोई प्रमाण नहीं है। तो जो पेशेंट चौथे पाँचवें दिन अगर उसकी तबीयत ठीक नहीं है या उसको बहुत तेज़ बुखार है या बहुत बीमार है, सांस में तकलीफ़ हो रही है या ऑक्सीजन कम हो रहा है, तो उसका CRP और CT स्कैन होना चाहिए। उस हिसाब से उसको फिर इलाज में स्टीरॉयड देना चाहिए।
बहुत इंपॉर्टेंट पॉइंट्स देखिए आप लोग ने जाने हमारे एक्सपर्ट से अबाउट यूज। सो अल्टीमेटली लास्ट पॉइंट एंड देन वील समराइज। डॉक्टर कटारिया एंड मे बी डॉक्टर खिलनानी, ये ब्लड थिनर्स भी लोग दे रहे हैं और काफ़ी रोल भी है इम्पॉर्टेंट। वी सॉ दैट इन द डेल्टा वेव। वेयर डू यू प्लेस ब्लड थिनर्स? एंड ब्लड थिनर्स मीन्स एस्पिरिन और एंटीकोगुलेंट। आर यू यूजिंग देम इन दिस ग्रुप ऑफ पेशेंट्स नाउ?
देखिए सर, जो डिफाइंड रोल है फॉर यूज़ ऑफ एंटीकोगुलेंट्स इज ओनली व्हेन द पेशेंट इज रिक्वायरिंग ऑक्सीजन सपोर्ट. Just because the patient has COVID, there is no role. And I have used very limited anticoagulants right now. There was a lot of problem in Delta wave because of too much inflammation. That post-inflammation after infection is very less this time. So, and this was like a lot of people, a lot of trials being done to give it only till hospitalization, 1 week, 1 month. And guiding it with D-dimer is also not so accurate, which I feel. Because measuring D-dimer is also fallacious sometimes if the sample is kept for a longer time and it's processed little later. It can be.
Yes.
So it has to be whether a patient is diabetic, has prothrombotic states, then only. Otherwise, anticoagulants in this particular wave, very limited.
Very
role.
limited use. So ये घूम फिर के बात ये आ रही है, देखिए कि इस समय जो केसेस में इंक्रीज है उसमें हमें पैनिक नहीं करना. देयर इज नो नीड फॉर पैनिक. Yes, we got to be careful. We have to maintain our masking. We have to maintain our COVID appropriate protocols as far as we can. We need not go obsessive about it, but we should not give up precautions, because remember, variants may change, but the mask will protect against all variants. So I think those are very important things for us to keep in mind. जहाँ तक ड्रग्स का सवाल है, ओवरऑल मेडिकेशन का सवाल है, डॉक्टर खिलनानी, अगर हम समराइज करें कि सिर्फ इस वेव में, इस वेव बोलिए चाहे आउटब्रेक वेव तो नहीं है ये, तो क्या ड्रग्स यूज़ की जा सकती हैं, की जानी चाहिए?
बहुत अच्छा प्रश्न पूछा है. तो मैं ये कहना चाहूँगा कि फिर से कहूँगा कि कोई किसी के चेहरे पे लिखा हुआ नहीं है कि ये ओमिक्रॉन है या आगे कोई सीवियर इलनेस नहीं होगी. मेरा अब तक भी थिंकिंग ये है कि जिनको बहुत ज़्यादा कोमॉर्बिडिटीज़ होती हैं, वो मैं फिर से रिसाइड नहीं करना चाहता. जिनको रिस्क ऑफ डेथ, रिस्क ऑफ सीवियर इलनेस ज़्यादा होती है, वो कोविड पॉजिटिव होते हैं, मैं उनको चॉइस देता हूँ. और मैंने एक्चुअली दिया है कि रेमडेसिविर 3 दिन के लिए लगाएं, उसे 85% प्रोटेक्शन मिलता है. और अगर वो नहीं एडमिट होना चाहते या हॉस्पिटल नहीं आना चाहते तो 5 दिन के लिए मोलनुपिराविर मैं उनको देता हूँ. हालांकि मैंने ये भी मानता हूँ कि सीवियर डिजीज़ नहीं है, लेकिन वो उसका बेनिफिट मैं अभी भी देता हूँ जब तक कि क्लैरिफाई नहीं हो जाए कि बिल्कुल 100% से माइल्ड इलनेस है. लेकिन आंखें खुली रखना ज़रूरी है, क्योंकि चौथे 5वें दिन तक अगर मरीज़ ठीक नहीं हो रहा है या उसका ऑक्सीजन कम हो रहा है या तो फिर तो मैं उनके टेस्ट कराता हूँ. उसमें ब्लड काउंट, CRP और डी डाइमर को मैं सोचता हूँ कि सबसे इम्पॉर्टेंट है. अगर वो डिरेंज्ड होते हैं तो मैं आगे चलता हूँ, अदरवाइज़ मैं उनको दूसरा मैं अपना एक्सपीरियंस बताना चाहूँगा कि इन दिनों मैंने कुछ केसेस 4 से 6 हफ्ते बाद में माइल्ड इलनेस के बाद में थ्रोम्बोटिक इवेंट्स मैंने देखे. तो जो लोग, जैसे डॉक्टर कटारिया ने बोला, जिनको कि हाई प्रोबेबिलिटी ऑफ थ्रोम्बोसिस होता है बिकॉज ऑफ देयर अंडरलाइंग इलनेस, नॉट नेसेसरली बिकॉज ऑफ कोविड, उनका मैं डिस्चार्ज के बाद भी या रिकवरी के बाद भी डी डाइमर और CRP और CBC कराता हूँ. और कुछ लोगों को मैं एंटीकोएगुलेशन, जिसमें एपिक्साबॉन और रिवरेक्सोबॉन 2 दवाइयाँ हैं जो काफ़ी सेफ मानी जाती है, उसकी रिकमेंडेशन है 30 से 35 दिन तक दे सकते हैं, लेकिन वो अंडर सुपरविजन. थैंक यू.
तो बेसिकली व्हाट वी आर सेइंग इज दैट इट नाउ कम्स टू stratifying the risk for the patient who is affected by COVID-19. The vast majority will fall into low risk and will require very little more than some paracetamol, some maybe anti-cough remedies, those kind of treatments. A small fraction which experts will identify for you, which your doctor will help identify whether you fall in that. Those who are at high risk for complications and have major underlying disease are the ones that require special attention. And as we know, in most cases, the fever or the symptoms are settling in 3 to 4 days. And if they don't, then there is reason to see the doctor for sure and get yourself checked up. So, यही अभी मैसेज है कि इस समय जो कोविड-19 की परिस्थिति है देश में, उसमें केसेस ज़रूर बढ़े हैं, लेकिन अधिकतर माइल्ड केसेस हैं. जैसे जीनोमिक स्टडीज़ आएंगी तो और पता लगेगा कि कौन से ओमिक्रॉन स्ट्रेन्स हैं ये. कोई पैनिक की बात नहीं है, लेकिन अगर आप ऐसी वल्नरेबल पोजीशन में हैं, जो हाई रिस्क बार बार गिनाया गया है, कौन से लोग हाई रिस्क हैं, और अगर 3 से 4 दिन के बाद आप इम्प्रूव नहीं कर रहे हैं सिग्निफिकेंटली, तो आपको ज़रूर से मेडिकल अटेंशन सीख करनी चाहिए. और किसी को भी ज़ुकाम खांसी होता है, अगर कुछ भी सिम्टम, आजकल सीजनल फीवर्स भी बहुत चल रहे हैं, जिसको हम लोग सीजनल बोलते हैं, वो एलर्जीज रह रहे, तो उसमें टेस्ट करने में कोई ख़राबी नहीं है. टेस्ट ज़रूर करना चाहिए, क्योंकि टेस्ट अगर पॉजिटिव आता है तो आप अपने आप को आइसोलेट करें, जिससे कम से कम आप इस वायरस को फैलने से रोक सकें. Thank you very much. Thank you for being in the studio, Dr. Khilnani, Dr. Kataria. Thank you, viewers, for being so good and staying with us for so many months. And we did last week discuss the science of this current surge that we are seeing. And today we have focused largely on treatments for your benefit. Thank you.